Imagine feeling constantly thirsty, exhausted, and not knowing why. This can be diabetes, something impacting millions every single day. Hi, I'm Dr. Joe Marquez, and I'm a family medicine physician. My goal in creating these videos is to help increase the level of intuition people have about their bodies and their health. I have a passion for medicine and really enjoy unraveling the complexities of the human body so that people can appreciate what is actually going on. I chose diabetes today because it touches so many lives, and understanding it can make all the difference. A good place to start will be with just some basic physiology. If you had to summarize diabetes in one word, it will be sugar or glucose, specifically too much of it. And glucose is the main currency of the human body. What I mean by that is if you take this gumball machine and you can see that each gumball was 1 penny, if you really wanted a gumball and you had $100, you can obviously afford a good number of these gumballs. But if you had your $100 in a form of a single $100 bill, then you wouldn't be able to get any of these gumballs because this machine only utilizes pennies. Similarly, the human body prefers glucose for most of its transactions. In other words, every cell in the human body can get energy from sugar. But not every cell can get energy from other means, whether that's fat or protein. Given this, the body, or the blood specifically, provides a constant supply of sugar so that every cell that needs it can get it. And if you were to look at the blood and see what would be a healthy amount to have, it will be roughly 70 to 100 milligrams per deciliter. And what this means is if you were to get a deciliter of blood, which is a tenth of a liter, you should expect to see 70 to 100 milligrams of glucose in that amount of blood. Think of the blood vessels as a freeway system that takes everything the cells need to them and takes away all the trash that they produce away to be expelled. But like anything in life, too much or too little of something can be a bad thing. So whenever we eat, one of the goals of eating is to get the glucose from the food into our bloodstream so that our cells can use it as they need it. But what happens if that level gets too high or too low? What if it begins to drop below 70? And what if it gets too high above 100? So in order to maintain the blood concentration of glucose between 70 and 100 milligrams per deciliter, these four structures kind of have to work together. The pancreas, just muscle, fat cells, and the liver. Now, these two, the liver and the pancreas, they're pretty close to each other. If you were to look at your abdomen, they're pretty high up, right beneath your lungs, on a little bit more in the middle and on your right-hand side. When you eat, what you eat and you absorb, the sugar gets eventually dumped into your bloodstream. And if the amount that goes into your bloodstream pushes it too far above 100, the pancreas will respond. And how the pancreas responds is that it will release insulin. This is a protein, and this protein gets dumped into the blood as well, and it swims around your bloodstream. And eventually, it will find its way to your muscle cells, to your fat cells, and to your liver cells. And when it goes to these cells, it will encourage those cells to suck up some of the sugar in the blood for their own use. So they actually benefit from this. So now they can essentially utilize it for their own nutrition, but by doing so, it also lowers the amount of sugar in the bloodstream. So insulin gets released when your blood glucose level gets too high. Vice versa, if your level gets too low, whether that's from starvation or too long of fasting, and you burn through all your sugar supplies, if it gets too low below 70, your liver is a primary organ that responds. And what happens to your liver is your liver utilizes proteins, specifically certain proteins, or certain amino acids, I should say, and converts those back into sugar. And by doing so, it essentially burns some of the protein or some of the protein in your body along with some fat for energy to then make sugar. So think of it almost like Legos. If your sugar gets too high, your pancreas responds by releasing insulin. That makes that excess sugar to go into your cells and be stored for a future day or burned for current use. That future use stored sugar gets transformed into fat. If the sugar level gets too low at one point in time, then your liver will eventually start to use some of the protein and convert that into sugar to bring it back into this normal range that your body likes to be in. What are the consequences of your glucose getting too high or too low? So if your glucose level gets too low, the consequences can be severe pretty darn quickly. Patients might begin to be unresponsive, comatose, so much so that whenever a patient comes to the ER and they're very, very just not responding or just very, very tired, one of the first things we do is check their glucose level and see if it's too low, and if it's too low, correct it. But like we mentioned, one of the biggest defenses for your glucose being too low is your liver creating new glucose. But with diabetes, we understand the issue that the glucose gets too high. When it gets too high, the body will try and correct that by releasing insulin. But over time, if a patient is living with a glucose that is higher than what it should be, there are some tissues in the human body that become a little bit damaged. One is the eyes, two are nerves, and three is the kidney. Now, if the eyes get affected, it's pretty obvious, right? You're going to have issues with your vision. If nerves get damaged, then you're going to have issues with whatever that nerve is supposed to do. And the most common nerves that get affected are the nerves of sensation. So a lot of times patients with diabetes can't feel their feet, can't feel their hands, and with time it kind of gets worse and worse and worse and worse. And then the third one here is with the kidneys. As the kidney is exposed to too much sugar over time, it will begin to degrade the kidney and decrease its ability to filter. And with time, once the kidney function gets too bad, the patient might require dialysis, which means a machine does what the kidney is supposed to do for the patient. And by far the most common cause for someone needing dialysis is diabetes that's just poorly controlled. And so all three of these things here are caused by the inflammation that the high sugar has in these types of cells. But another thing that gets affected is not just these things, but blood vessels. And what happens here is right here we can see a pretty healthy looking blood vessel. It's a tube, same size throughout, there's no narrowing here. But as there's a lot of sugar in here, that causes inflammation to occur in the blood vessel. And that inflammation over time may cause some plaque buildup. So this yellow stuff here that we can see, here's the long axis of the vessel, and here's a short axis. We can see this plaque begins to narrow this tube. And as the tube gets more and more narrow, less blood can go through. Now, if this was a vessel that was going to the heart, or if it was a vessel going to the brain, then we can say that can be a very problematic thing, because if it goes to the heart and it doesn't let the heart get enough blood, then we will call that a heart attack. If it goes to the brain and the brain can't get enough blood, then we call that a stroke. But even if it was just blood going to a muscle or to a limb, eventually that limb may not be able to get enough blood, and the limb will begin to have problems, and with time it might get worse and worse. And eventually, it might get to the point that we have to actually just amputate the leg. And that's why amputations are so common in diabetics, is that the inflammation the high sugar causes in the blood vessels compromise the blood flow to the entire limb. And it might get to the point that the best thing to do actually is to remove the limb entirely. Look at diabetes. We understand the whole issue is that the sugar gets too high. But there's two flavors of diabetes. One is called type 1 diabetes, and the other is type 2 diabetes. Now, it's called diabetes mellitus, mainly because of what those words mean can be very informative. Diabetes just means high urine volume. So you're peeing a lot. And then mellitus means sweet. So the word diabetes mellitus here, the DM, just means that you have a lot of sweet tasting urine. And this is actually how the Greeks first noticed that they will literally taste urine and say, oh, it's very sweet because there's sugar in there. There's so much sugar in the bloodstream that the kidneys can't filter it all and some of it gets lost in the urine. Okay? I understand it's not the best mind image there, but that's where the name comes from. One, like I mentioned, is type 1 diabetes. These patients tend to be younger and they tend to be healthier. There's always exceptions, of course, but that's a generality. What happens here in type 1 diabetes is that it's an autoimmune disease. What autoimmune means is that your own immune system, which is designed to protect you from foreign invaders, bacteria, attacks your own cells. In this case, it attacks the cells of the pancreas that actually produce insulin. So, in theory, this might be a healthy person with no other issues. They encounter a virus, they encounter some kind of infection. We're not entirely sure what actually upsets the immune system, but something happens, it sparks the immune system. The immune system then attacks the pancreas, and now this poor patient can no longer produce any insulin. And remember, if there's no insulin, the body loses its best defense against high sugar levels. Thus, these patients need to receive insulin through injections in order to replace what they can no longer make. And because it can happen pretty quickly, they can be normal functioning pancreas, and then within hours, days, weeks, in some cases, it could be a little bit longer, but over a relatively short period of time, this patient is not diabetic. Whereas if you look at it, type 2 diabetes, it's a little bit different. The issue here is more insulin resistance. And what's happening here is that the pancreas is being exposed to so much sugar that it's forced to release as much insulin as it possibly can. And with time, it's just being overworked and overworked and overworked. And it can get to the point that these poor pancreatic cells that produce insulin burn out. And so if we were to look at this diagram over here, just to kind of get a better understanding of how insulin works, let's say these yellow stars are sugar molecules in the bloodstream. And when that gets too high, the pancreas then releases insulin. This triangle, we'll say, is an insulin molecule. As of right now, the sugar molecule cannot get into the cell. There's no way for it to get through. But the moment this insulin molecule attaches to this insulin receptor on this cell, then once they attach like they do here, this green protein is a glucose channel that gets transmitted or moved from inside this cell to the cell surface. And because it's now on the cell surface, sugar cannot come in. And by coming in, now this cell can feed itself. And it lowered the outside sugar level. So that's kind of how it works. Insulin should get released. Once it gets released, it attaches to this receptor. Now, the cell that has the receptor is able to essentially absorb some of the glucose, which means that some of the glucose in the blood gets lowered. But in type 2 diabetes, the issue is that there's so much insulin. So that here, the same thing. Here you have one cell with all the insulin receptors. Here's the insulin molecules. There's just so much insulin that the cell is forced to decrease the number of receptors. That might seem counterproductive, but it's similar to when you put on a shirt. There's this principle called sensory adaptation. When you put on the shirt at first, you're very aware of the shirt's texture, very aware of the shirt's stiffness. But after a short period of time, you no longer register that. And you don't really feel your shirt unless you actually think about it and want to feel your shirt again. What's happening there is the cells that are getting that input from that stimulus, which is the shirt stimulating your skin, over time, the signal gets deadened. It's not as responsive to it, because how the body responds best is to a new stimulus, not an old stimulus. So here, this cell is being bombarded with so much insulin that it actually decreases the number of receptors available to it. And because of that, in order for this cell now to take up the same amount of sugar it did before, it'll require a lot more insulin. And so we term that insulin resistance. And so when you go back over here and we're trying to focus on type 2 diabetes, these patients over time have stressed out their pancreas to the point that the pancreas has to release more insulin. And because more insulin is being released, the cells that are supposed to respond to that insulin become more resistant to it. And because of that, the sugar level begins to essentially get higher and higher than 100 milligrams, per deciliter. And as the sugar level gets higher, because of the resistance of the cells, the pancreas is forced to release more insulin. And by releasing more insulin, over time, the cells become more resistant. And you get this vicious cycle. And as the sugar level gets higher and higher and higher, it begins to damage your kidneys, it begins to damage your eyes, it begins to damage your nerves, it begins to damage your blood vessels. And so this is how this diabetic vicious cycle leads to problems over time. In both type 1 and type 2 diabetes, the most common cause of death in both of them is cardiovascular disease. And what that just means is, if you go back over here, this is cardiovascular disease, meaning the blood vessels are compromised. Whatever this blood vessel feeds will now suffer the consequences of not getting enough blood. So when someone says that they're having, so when you look at the news and you say cardiovascular disease is the most common cause of death, that includes in this umbrella term heart attacks, strokes, and various other organs that begin to fail because of blood supply issues. Now, if you were to go back to comparing these two things, like I said, in both of these patients tend to die from cardiovascular disease when compared to the normal population, those who do not have diabetes. But when you compare type 1 to type 2 diabetes, you see that type 2 diabetes have a much higher rate of cardiovascular disease. Moreover, if you were to just focus on these patients, and if with medications and treatments, we are able to normalize their sugar levels, so get them back into the 70s to the 100s, or quite close to it, we do see that the issues with their eyes, with their nerves, and with their kidneys get much better. By normalizing the sugar levels of a diabetic patient, it rescues their eyes, their nerves, and their kidneys. But for one reason or another, it does not rescue the blood vessels. So the risk of a patient with diabetes having a heart attack or a stroke stays high even though the sugar levels are normal, which was quite shocking to us as a medical community, because we assumed that as we normalize the sugar level, all the consequences of diabetes will begin to then improve. And because it is not, we are shifting our management of diabetes, but we'll talk into that a little bit more in depth later on. Just want to make sure we understand that patients with type 2 diabetes, the end-all be-all is never to correct just the glucose level, because just by doing that does not necessarily decrease the risk of dying from a heart attack or a stroke. But how do you know if someone has diabetes? One is just a fasting blood glucose level above 126 milligrams per deciliter. And what this means, fasting, it means no food, so empty stomach for at least 8 hours. So overnight, typically. Have a patient wake up, before they eat anything, come to the clinic, come to the laboratory, get the blood drawn, and if that blood draw comes back above 126, we say that person potentially has diabetes. The problem with this test is that even though it is pretty accurate to tell us who has diabetes, if someone comes with a level of 119, Does that mean they do not have diabetes? And the answer is no, because somebody could essentially just fast for a little bit longer than 8 hours. They could start eating healthy for just a day or so, and by doing so, alter the amount of sugar in their bloodstream at that time. And so, if someone comes in with a blood glucose level of 115, fasting, it doesn't tell us necessarily the patient does not have diabetes. Another test, a second test, is to get a random, meaning non-fasting, blood glucose level that is above 200 milligrams per deciliter when they have symptoms with, and this is a fancy little shorthand saying with, symptoms. And symptoms of diabetes are going to be the polys, polyuria, polyphagia, and polydipsia. What these are, polyuria means that you're peeing a lot more than normal. Sugar gets lost in the urine, and as sugar gets lost in the urine, it draws fluid with it. And by drawing fluid with it, the person will end up peeing more than they normally would. Polyphagia means they're eating more than normal because of the fact that they're dumping so much sugar or calories in the urine. Again, there should be very little to no sugar in the urine of a healthy person because sugar itself is a very rare commodity. But by losing so much sugar in the urine, the patient has a higher appetite, and so they will begin to eat more. And polydipsia just means they're drinking more because of the fact that they're losing so much fluid. They're peeing more, losing more fluid, so they're having this necessity to essentially drink more to replace that lost volume of fluid. But again, both of these are very helpful to tell you someone has diabetes, but neither is very good to tell you that someone does not have diabetes. In order to answer that, there's probably the most accurate test. It's called a glucose tolerance test. And what this is taking 75 grams of glucose, usually in some kind of drink, and then 2 hours later, after they drink it, if their blood glucose level is over 200, that tells us the patient has diabetes. But because we can see how the body responds to this glucose load of 75 grams of sugar, remember 75 grams is 75,000 milligrams, how they respond to that can help us determine that a patient does not have diabetes as well. So if a patient has diabetes, they will typically either not be producing any insulin, for an example of a type 1 diabetic, or have pretty extreme insulin resistance with a type 2 diabetic. And so this load of sugar will lead to them having a pretty high glucose level in 2 hours. But if someone does not have diabetes, their body can manage this very, very quickly, and within 2 hours, they're less than 200. Okay? But this test is much more accurate. It can tell us if someone has diabetes. It can also tell us if they do not have diabetes. But it is time intensive. It takes 2 hours to then come back, have another blood draw. So it can be a little bit of a nuisance. The fourth option is to check an A1C. An A1C is an indirect way to see what was the average blood glucose level in this patient for the last 3 months or so. And the reason it's 3 months is we are checking this person's hemoglobin. The hemoglobin themselves are housed within a red blood cell, and the red blood cell lives for about 3 months. Now, these hemoglobin molecules require glucose to essentially stay alive, to feed itself, give itself energy. And the more sugar it comes in contact with, it begins to essentially attach itself to the hemoglobin molecule, similar to a car going in snow and the snow getting stuck on the car. And so if you go in the parking lot, if you look at a bunch of cars, you can then associate, oh, based on how much snow I see in the car, there must be that much snow outside of this parking structure. Similar with this test, we can essentially look at the hemoglobin, and based on what percentage of hemoglobin is stained with glucose, we can then extrapolate and say, well, this much sugar must be in the blood. So typically, if the hemoglobin A1C is above 6.5%, we will say the patient is diabetic. okay? But again, none of these tests are perfect. Hemoglobin A1C is not perfect. The oral glucose test with the 75 grams isn't perfect either. But these two tests are, as of right now, the best test to determine if someone's diabetic. Best in terms of accuracy, but also convenience. But what is becoming more and more common now is patients to actually have these continuous glucose monitors that give you real-time glucose levels, and they register and record what it has been. That allows us to be more black and white, and potentially could eventually make all of these things useless, because rather than trying to extrapolate or trying to then see how they respond to sugar, we can just look at this printouts, and they tell us what the patient's glucose level has been for the past weeks, days, months, however long they've been on this machine. But as far as the management, there's 5 key steps. The first is smoking cessation. Smoking cessation is very important because smoking causes so much inflammation of blood vessels. This by itself can cause heart attacks and strokes, let alone if you combine this with diabetes, it is set up for disaster. And so I always try my best to have patients who smoke and diabetic to really focus on getting them to stop smoking and decrease their risk of having these kinds of problems. The second is blood pressure control. Blood pressure itself can damage kidneys, can damage the brain, can damage the heart. And again, the combination with diabetes makes it even more problematic. So many times I try my best to try and keep patients in normal blood pressure, whether that's through weight loss, whether that's through diet control, exercise, or with medications. Third is actually medication, metformin. This is a drug that has been present for quite some time. It's kind of one of the old school drugs, but it's very effective. Its main way of working is actually by decreasing the insulin resistance the patient has in their body, and it also inhibits the liver from making excess glucose during inappropriate times. This is one of the few old medications of diabetes that actually has shown through a lot of data and research to decrease the risk of death from cardiac issues. The fourth is lifestyle modifications. This typically going to focus on the patient's diet. It's going to focus on the patient's exercise routine. Exercise by itself can really help drive sugar levels down. So there's many patients, especially with type 1 diabetics. Type 1 diabetics are athletes will be able to tell you that if they were to take their normal amount of insulin and exercise quite rigorously, they run the risk of having too low of glucose. So many times, even if someone's having some degree of insulin resistance and their cells are not responding to insulin too well, exercising is able to bypass that resistance and force those cells to actually take in glucose and thereby lowering glucose levels in the blood. So lifestyle modification, specifically exercising, crucial. And of course, diet, being mindful of how much sugar they are taking in, how much glucose they are taking in to help decrease the load of what the pancreas is going to have to then deal with. And the last one are the medications besides metformin. And with these medications, typically they're going to include a statin. These are designed to help with the cholesterol and lowering the amount of bad cholesterol in the bloodstream and thereby lowering the risk of cardiovascular disease. Then you also have some medications that work more directly on diabetes. GLP-1 agonists. So there's several of these. These tend to be injectable. This is like the Wegovy or Ozempic or Zepbound. They have a good benefit of weight loss. And not to mention, they help control the sugar in the patient as well. SGLT2 inhibitors. These medications can not only control one's glucose levels, but they also decrease one's cardiovascular risk. And so all three of these medications, the statins, the GLP-1s, and the SGLT2s, all decrease the cardiovascular risk that someone has from their diabetes. And the same with their metformin. The main reason why metformin has its own group is that it's so common, it's so cheap, it's so available. Most people should be on metformin for that reason. Screening is so important for diabetes because trying to prevent progression into diabetes is probably the best way of managing these things long term. And most of the things that we were talking about in the treatment phase, whether that is smoking cessation, blood pressure control, lifestyle modifications, all those can be started well before someone ever becomes diabetic. But another way we can screen for diabetes is checking for something called metabolic syndrome. And what metabolic syndrome, or any syndrome in general, anytime you see the word syndrome, it just means a collection of symptoms. And when you have these, when someone meets criteria for metabolic syndrome, that means these patients already have a heightened risk for cardiovascular disease. So that means heart attacks or myocardial infarctions or strokes, and they're at higher risk for diabetes. Okay, so all patients who meet criteria for metabolic syndrome already have this increased risk of these kinds of problems. And so if you can catch these patients and help improve them, you can not only avoid these issues, but get them more towards better health. Criteria for metabolic syndrome is one is abdominal girth. So if you're a man, it's more than 40 inches. For females, it's more than 35 inches. Okay, the next one is your blood pressure. If your blood pressure is over 130 over 85, that's another risk factor. If your A1C, now what we mentioned before was if you're over 6.5, technically that is the criteria for diabetes, if your A1C is 6.5 or higher. But if your A1C is between 5.7 to 6.4, then that's considered pre-diabetes, and that means that you have a higher risk of developing diabetes in the future, and is one of the risk factors for having metabolic syndrome. And so normal A1C should be a little bit beneath 5, like in the low 5%. Another will be with cholesterol, specifically the triglycerides. If your triglycerides are high in the cholesterol panel, that would be another risk factor for metabolic syndrome. And in that same metabolic panel, in that same cholesterol panel, if you have low HDL, which is the good cholesterol, that will be another risk factor for metabolic syndrome. And so here with metabolic syndrome, you have 5 characteristics. And of the 5, if you have 3 of them, then you meet criteria for metabolic syndrome. And by meeting criteria for metabolic syndrome, it means that the patient has a higher risk of developing diabetes in the future, a higher risk of having cardiovascular disease in the future. So we do our best to try and avoid that, prevent progression. And that's pretty much it. I hope you found that helpful, and see you guys next time.